Now I would like to invite Dr. Lauren Barenbaum, Professor of Medicine at University of Kansas Medical Center. Dr. Barenbaum has probably the most experience in this area with lead extractions, and he's going to share his experience about the tools and techniques of lead extraction. Dr. Barenbaum.
Thank you. It's a pleasure to be here. I want to thank DJ and Danita for the outstanding job they've done once again putting this together. I want to thank all of our speakers, and I want to thank everybody who came out for the meeting and has helped make it the success it's been so far. So we heard a great talk about infections. This is an example of a device that clearly has been eroded for a long time. These patients always show up and say, I looked in the shower this morning and my device was out, whereas clearly this has been out for months. And this is a system that is chronically infected and needs to be removed. Now, what you need to understand about removing leads is it's not something you decide to try for the first time because, gosh, the lead isn't very old. I'm sure it'll come out real easily because that will be the lead that acts like it's been in for 20 years. It's not a procedure that you start at 4 o'clock in the afternoon and get to the actual extraction when everybody else has gone home and the surgeons aren't around and the pump isn't around, et cetera, et cetera. So you have to do a lot of planning for these procedures. And the reason is that over time, a lot of scar tissue develops on leads, and they don't just fall out. Sometimes you have to work pretty hard to get them out. And sometimes you take out a scary amount of cardiac tissue. So those are pretty good size biopsies. This is just an interesting example. This actually shows you the scar tissue that developed between 2 leads. And these are both pacing leads, and I was getting them out, and I knew that I was free of everything related to the heart and the vessels, but I couldn't separate the leads. I was lucky in that these leads had actually been put in with 1-stick, 2-wire technique, and I thought, maybe if I just pull everything back, it'll come out, and in fact it did. Now, the leading indication generally for removing leads is infection. But there are many other indications which require much more judgment in terms of, when do you take it out and when do you leave it behind? And I think we'll touch on that a little bit at the end of the talk. Lead management, lead extraction is a program. It's not just a procedure. You need a physician champion who has both the cognitive skills, the procedural skills, and the volume to be good at this. You need a surgeon who is committed to helping, and again, who understands what the problems are, who has the surgical skills. And you need a surgeon who is quick. If you have, an incredibly good methodical surgeon, that may not help you very much, because if you get into trouble with these cases, time is of the essence. You need the surgeon who can get the sternum open and put his finger in the dike in 5 minutes, because if you've got the surgeon who needs 20 minutes to do that, it may all be over. You need to have well-trained people scrubbing with you, and you need to have a program manager. You need to have somebody who makes sure that all the tools that you need in your toolbox are there so that you don't ask for something in the middle of the case and get blank stares from everybody. And I think it's very important that you have a full toolbox when you do this. Basically, every tool that's been developed for extracting leads should be on the shelf if you're doing lead extractions. Again, you need to think about surgical backup. You need to have a formal plan. You need to make sure that everybody knows their rules, their roles. You need to have good communication. Who do you call? And where do you call them? What equipment do you need, et cetera. In terms of extraction tools, you need a bunch of implant tools because a lot of times you're extracting and reimplanting, and you have complicated reimplantation. For the superior approach, you need locking stylettes. I would say you should have the laser system, the mechanical sheaths, the evolution system, a variety of accessories. And then, although we tend to use the inferior approach less, sometimes it's the only way you're going to get leads out, and so you need to have the tools for the inferior approach. In terms of what's going to make a lead extraction difficult, the age of the leads is relevant, the number of leads, type of leads. Older leads tend to be non-isodiametric. Isodiametric means the whole lead is the same size. Non-isodiametric means that somewhere along the lead body, somebody designed a lead where it gets fatter, and those leads are going to be much more difficult to extract. Passive leads tend to be more difficult to extract. ICD leads tend to be more difficult to extract. Lead location may be permanent. Lead interactions, and so the more leads you have, the more opportunity there is to have scar between leads. And then how much slack is on leads. If you see a lead that's sort of running straight into the heart with no slack, there's probably fewer points of attachment. If you see a lead with a lot of slack on it, there are probably more points of attachment. In terms of pre-case planning, what are the comorbidities? What's the ejection fraction? What's the patient's pulmonary status? Do they have, are they obese? Do they have diabetes, renal insufficiency, ASA score? And you need to know what's in there. And I think one of the keys to knowing what's in there is that you need to have a chest X-ray. Because some of these patients have had devices for 20 or 25 years, and you scour through the records and you think, okay, there's 2 leads in there, and you take a chest X-ray and you find out there's 5 leads in there. In this particular case, you've got a couple of ICD leads. The coils are lying right against each other. The coils are lying in areas that, especially up there in the SVC, where tissues are not very strong. It's easy to get into trouble. With those 2 coils lying right on top of each other, there's probably a lot of scar tissue between the coils. And that doesn't look like a real wonderful chest X-ray. Where do you do this? I think current state of the art, the best way to do these is in a hybrid suite where you've got high quality X-ray, and all the tools that, as an extractor, you need. On the other hand, if you're in the hybrid suite and you get into trouble, you don't have to move from one place to another. And again, when time is of the essence, that saves you time and gets your surgeon going much faster. In terms of procedural considerations, basic blood work, you want to have blood typed and crossed. You need large bore venous access. You want more than 1 IV. Generally, you're going to want femoral venous access so that if you need to get a temporary pacemaker in quickly, you can, so that if you need to give more fluids, if you want to put a balloon in from below and try and occlude what you think is a damaged superior vena cava. So you want that extra access. You want to have continuous blood pressure monitoring, because you don't want to be getting Q5-minute blood pressures. If blood pressure starts going down, you want to know about it right away. Sometimes just tractioning on leads will cause the blood pressure to drop, and you need to take that into account as you're doing things. Obviously, you want to have the patient ECG monitored. We have really gone to doing general anesthesia. almost all cases. Now, if you've got somebody with, 1, 2, 3-year-old leads, et cetera, and you think there's a good chance that they're just going to come out with gentle traction, then you may scale back on some of these things. But that's likely to be the lead that turns out to be tough, and you wish you had done everything. So it's good to be in position to have everything set up for you. The high-risk cases, we'll put a TE in place, and you want to be able to have pacing and defibrillation therapies available, obviously. When you get into the pocket, get the device out, you want to clean up all the leads and all of the scar tissue over the leads. You're going to look at the pocket for signs of infection. If you're taking out some leads and leaving some leads, you want to check the performance of the leads that you're leaving behind, because if you don't, and at the end of the case you check them and the numbers aren't quite what you expected, then you wish you had the baseline data. I think what I've learned is that if you think you've yanked on a lead too much while you're getting something else out, it's better just to get that other lead out than to come back 6 months or a year later to do an additional procedure. And for the leads that you are leaving behind, you want to try and reinforce them a little bit. So you want to put a non-locking stylet, just a standard stylet, at least part way down them, to give them a little more stability. If you've got an active fixation lead, you try and unscrew the helix. Most of the time you can, but not always. Depending on how old the lead is, you're going to try some gentle traction. The emphasis is on very gentle. All of the leads that we use are made of coiled wires, and if you pull on them a little too hard, then everything starts falling apart and the coils start stretching, and then you've got pieces of lead left in the patient, and it makes it much more difficult to take the lead out. You want to amputate the header off the lead, isolate the inner coil. Mostly we have bipolar pacing leads in people. And you want to lock all of the leads, put a locking stylet in each of the leads you're going to remove, and then you want to secure the locking stylet to the lead body, either with a suture or with a new little gizmo called a one-tie. And so here's a picture of a target lead. So again, you need to isolate that inner coil so that you can control it as best you can. This is an example of one of the types of locking stylets out there where it goes down in low profile, but you can sort of spring that wire at the end, which will lock in and make stretchy coil into a fixed rail that you can use for extraction. This is an example of putting a silk suture over a lead, and what happens is the silk will absorb blood and fluids, and all of a sudden it's big and bulky and you can't get your sheath over it because you've got this huge knot in your way. This is a little gizmo that's actually very handy. It's new. It's called a one-tie. It's a very simple concept, and simple things are often the best. A couple of wires, a couple of little tabs to hold them, and you basically twist that around the lead. So you take the outer insulation, the outer coil, the inner insulation, the inner coil, and you make it all into one very cohesive unit. When you have an ICD lead that's going to have some straight cable wires in it, it again turns all of that into one unit that really holds together very nicely. I think this is a nice little improvement over what we used to do just a few months ago. Now, when I started doing lead extractions 20 plus years ago, you had some inferior tools, and from above you had various types of plastic and stainless steel sheaths, and you'd work those down mechanically and break up the scar tissue. I would tell you that I think it's probably the safest way to get leads out, but it can take a lot of work, and you can't break through some scar tissue with these tools. It's simply the scar tissue is too tough. And so over time, we have developed powered tools. This just shows in terms of technique. So there's the tip of a sheath. Here's your lead, which is kind of zigging and zagging, and you are not in a good position to remove that lead. What you want to do is have your sheath lined up going in the same direction as the lead. And so in this previous example, you basically need more traction on your lead than you have in that situation. It's going to be a safer, more successful extraction. This looks at, this happens to be a laser sheath, but basically the tips of these sheaths are beveled, and you want to orient the bevel so that the leading edge of the bevel is on the inside of your curve, not poking out and trying to poke a hole in the superior vena cava there. So this shows common location of binding sites, areas where you tend to get scar tissue. And you can see there are a lot of areas that you tend to get scar tissue. And this shows location of potential complications. Well, guess what? It's every place that you get scar tissue. My only comment about this particular slide is that you should just put a circle around the whole chest, because there are areas that you worry about more and areas that you worry about less, but there is no area that is safe and where you just have that, where you can totally relax. So the laser sheath has been with us probably 15 years. Just in the last year or so, they have improved the laser sheath, and actually they haven't changed hardware at all. What they did is change the pulse repetition frequency. They give you 80 hertz of laser instead of 40 hertz of laser, so you get twice as much laser per second. And what that shows is that with constant force, you can advance more quickly, and it also shows that you can advance with less force. I have to tell you that in approximately 25 years of removing leads, I've had 4 people need surgery, all with laser sheaths, and 2 of the 4 with glide light sheaths with the 80 hertz. So personally, I crank every laser sheath down to 40 hertz when I'm using it, and I'm not the only one. It's not randomized data, but I think there are a number of extractors who feel like, yeah, the glide light gets you through a case faster until you poke a hole doing something. The issue is not really that I had complications with these 2 cases with the glide light, but rather that I thought from a technical standpoint that things had gone smoothly. It wasn't one of those cases where you kind of under your breath go, uh-oh, I hope I get away with that. Because I think we all know about those moments in whatever type of cases we're doing. But cases where I thought what I was doing would be completely safe, and it turns out that it was not. The evolution is a mechanical system, and it has these little, it actually rotates, and you see these little blades on the tip. It has been improved, and the nature of those blades has changed so that you are less likely to coil things up and do something like this. And this was a lead that I couldn't get out with laser, and I wasn't going to get out at all, and I was using the evolution, and it started coiling up, and I knew that was a bad thing, but I figured, you know what, I will get the lead separated from the tissue, and then I'll figure out how to get the lead out of the patient. And in fact, by winding it the other way, it eventually did come out, and that case went well. Complications are less likely if you're more experienced. So if you're a new extractor, you want to look for cases that you think should be relatively easy and relatively low-risk situations. You want to gradually increase the complexity of cases that you're doing. According to recommended guidelines, in terms of experience, you should have worked on 40 leads in training, and you should do 20 leads a year as an extractor. You look at some of the large database information. If you're getting extracted at a busy center, and busy is defined as only 130 cases in 4 years, so really not high volume, but the risk of complications is much less than in less busy centers. You're more likely to run into complications in your first cases. Complications continue to decline through several hundred cases. I think in terms of lead management, what you need to think about is what plan do you need for your patient? Do you need a 5-year plan, a 10-year plan, or a 50-year plan? So for instance, if you have a patient with a 5-year-old Fidelis lead, they're up for a generator change. Fidelis function is normal. It's a primary prevention device. They're not pacer dependent. Well, in case 1, it's an 82-year-old with an ischemic cardiomyopathy, EF of 20%, multiple comorbidities. I'm likely to put my chips on the lead lasting longer than the patient. Case 2, a 20-year-old with long QT syndrome. The sister had sudden death at 17. This patient has a structurally normal heart. I can tell you that she got a generator change at age 20, and I saw her for her lead extraction at age 22 after she fractured her Fidelis lead. And she actually lives in Springfield and will be following up with Dr. Turla. So I think that's it.